Good morning.
Good morning. Is this Bob?
Yeah, how are you?
Good, good. Hey, all right. So what do I need to do here now? I'm looking at myself on the screen. I see you. Okay.
You did you join oh, there you are. Now, are you going to join with your computer?
I'm not sure.
Well, that's how you share your. Okay.
I mean, I'm on my computer right now. I can should I go? I tell you what, should I go
Join
to
with your
my
computer. You should have joined this Zoom with your computer.
okay. So let me go back to, I think it's right here. Because the thing that Brian sent me, let's see. Should be something here. I know he sent it to me. Oh, here we go. Brian Smith.
You probably have to log out on your phone.
Okay, I'm just kind of talking. Let's see. He said he. Okay. So here is okay. So here's it on Soul posted. Okay.
Okay. You have to join Zoom with your computer, not your phone.
How do I get on Zoom then?
The same way you did on your phone. Is there a link in your you log into your Zoom room and call this one? So you had Zoom on your phone. Have you ever logged in on your computer before?
Yeah, I usually just do it with my phone. Let's see. I thought
you know what? I downloaded the video. I'll just start it from here.
Okay, that would be easier because I have like a different. I have a laptop computer or whatever, but if you have it from there, that would be great. Just looking at my calendar. Are you still there?
Yeah.
Okay. So again, I'm pulling up on my computer under calendar under.
Yeah, it's right. It's all right. I've already switched it here. We'll just go ahead and mute your mic, and I'll start it at 8 o'clock.
Okay.
Your phone camera, you might want to mute it.
What's that?
You might want to mute your phone camera.
Okay. How long is the presentation, Bob?
53 minutes.
Okay. So now at the end of it, do I need to do anything?
And no, I'll shut it off.
Okay.
So,
perfect. Thank you very much.
All right.
hospital-based medicine doctor. Today's topic is on why can't I order that drug? Why can't I order that drug and not another? Looking at factors and hospital formulary development and maintenance. I'm not a pharmacist. I don't play a pharmacist on television, but I have worked in pharmacy on a variety of topics over the years. I see many questions that arise from residents as well as colleagues in terms of why are certain antibiotics restricted? Why do I feel like I'm being restricted to one antibiotic over another? Why can I order a particular medicine if they're on the statin or an ACE inhibitor? Why can't I get the one that they normally use at home? Why do drugs sometimes change? Tygan or Synergy, why can I order them one week and maybe not the next? What are some of the new developments? How do I keep up with these? Are there any reference tools? Are there any reference tools to keep me up to date? And finally, what happens when I see something that doesn't go like possibly? And specifically in response to the COVID pandemic. And then hopefully, ultimately the goal is to acquire a little bit better understanding about what goes on behind the scenes regarding formulary development and management. As a side topic, many of you have seen these signs around town. Obviously, our frontline workers that respond to COVID people, care for COVID infected people, are looked up as heroes, and they should be, because they are. Good morning, and thank you for tuning in. Today's Grand Rounds. I'm Dr. Carl Palmer. Most of you know me. I'm your friendly school teaching, hospital-based medicine doctor. Today's topic is on why can't I order that drug? Why can't I order that drug and not another? I'll look into the factors in hospital formulary development and maintenance. I'm not a pharmacist, and I don't play a pharmacist on television. But I have worked with pharmacy on a variety of topics over the years. I see many questions that arise from residents as well as colleagues in terms of, they come up such as, why are certain antibiotics restricted? Why do I feel like I'm being directed to order one antibiotic over another? Why can I order a particular medicine if they're on a statin or an ACE inhibitor? Why can't I get the one that they normally use at home? Why do drugs sometimes change, like with Tygan or Phenergan? Why can I order them one week and maybe not the next? What are some of the new developments that come up? How do I keep up with these things as they come up? Are there any reference tools that can keep me up to date? And finally, what happens when I see something that doesn't go right that I think is possibly an issue that pharmacy needs to look into? How can I report that? And then we're going to talk a little bit about the event management system, or EMS, formerly known as the PSN. So today's objectives are basically what I'd like to do, just start out reviewing a national healthcare expenditure. We're going to look at an overview of WVUHS and healthcare systems, Pharmacy, Nutrition, and Therapeutics Committee. I want to illustrate how the formulary is developed and maintained with specific examples. I want to talk a little bit about quality measurement in our pharmacy, and is it making WVU a safer place? I want to present a few new issues that are facing our pharmacy, and specifically in response to the COVID pandemic. And then hopefully, ultimately the goal is to acquire a little bit better understanding about what goes on behind the scenes regarding formulary development and management. As a side topic, many of you have seen these signs around town. Obviously, our frontline workers that respond to COVID people, care for COVID infected people, are looked up as heroes, and they should be, because they are putting their, they're doing a high risk activity, and they certainly deserve a lot of attention. They sometimes compare themselves to heroes, which they are, and sometimes actually to superheroes. And that kind of got me to thinking a little bit about, should we be comparing ourselves to superheroes? So this is going to be a little bit of a lighthearted attempt at a little bit of humor in an otherwise somewhat strange world that we live in right now. So starting out, just kind of setting the table with some basic stats. You can find these online. Basically, there's about 330 million people in the United States. Almost half of them have taken a prescription drug within the last month. About 25% or a quarter take 3 or more prescription drugs at any one time. And if you look at people over age 50, 75% of adults are taking medications, prescriber medications. As you can see, people over age 65 comprise about 14% of the population, but use about 40% of the prescription drugs. So these, a lot of things, a lot of people using a lot of drugs, most of which is very well-intentioned and appropriate. Still, at the same time, healthcare is a very expensive industry. If you look at 2017, the national healthcare expenditure was about $3.5 trillion, about 18% of the gross national product. Spending has continually increased year after year. There's lots of drivers in prescription drug expenses, and this is across the nation, not just here. But utilization is new indications for new drugs all the time. Their cost is always an issue. Newer drugs cost more, and most drugs that come on have about a 5-year patent, and then they can charge whatever market value is at that time. Sometimes once the patent is removed, there's delays in getting generics introduced into the regimen of medicines available to pharmacies. The supply chain is complex. There's wholesale, retail, mail-in, all types of things going on here. There's certain specialty pharmacies, which has become more popular. I think many of you have heard of Gilead Science. They actually introduced Sovaldi, which is a hepatitis C treatment, about 10 years ago. Now that's the company that makes remdesivir, which is one of the treatments for COVID-19. Again, their reimbursements kind of dependent upon how good their drug actually works, what kind of therapeutic response you get. The United States pays more than other countries for the same drugs for some reason. And then finally, just to comment, the drug mix. This is where formularies come into play here. This is not just for hospital formularies. It's also for HMO. It's for third-party payers. It's, such as West Virginia Medicaid, Medicare, all those things, looking at efficacy, safety, and purchasing. So it's a very complex process. If you look at it from a graphing standpoint, if you look at this, CMS basically is, kind of the retail cost of drugs, and then you can look at some of the other things such as the ASPE. These are just different projections. One of them is just basically for retail, and these are like for retail and wholesale. But again, you can see on the order of, in terms of billions of dollars, about $300 billion. And the more important thing is just the sheer amount of money this is, and you can see it is increasing on a yearly basis. So our first superhero I wanted to mention is Superman, and again, he's sort of the man of steel. A couple questions about him in terms of, is he truly COVID responsible or not? I don't know about his immune system very well. He's from a different planet. He can shoot lasers out of his eyes, and that certainly could denature any COVID virus that's around, but the sheer mass destruction that would ensue probably make any benefits outweighed by the risk. So I was going to give Superman a thumbs down, but Dr. Feinberg in her grand rounds a couple of weeks ago was just commenting about, the risk of COVID spread is pretty minimal when you are moving quickly, and obviously Superman can fly. So my thought on Superman is, even though I was going to give him a thumbs down, as long as you can keep him in the air, you're probably pretty safe from Superman. Turning our attention a little bit more to locally, to WVU, I just want to give you some numbers to set the table here. We spend about $46 million at this hospital on the Hill for inpatient drugs per year. If you look at all the infusions and clinic and everything else, you're looking at a budget of about $200 million a year. And if you look at the overall system, WVU Medicine at this point is over $300 million per year. Ideally, we want to spend less than 22% of our pharmacy budget and supply budget on net patient revenue. Again, this is just sort of one way of measuring this. Another comment to make is, how many drugs do we have here? We actually have in this hospital about 1,600 different drugs. If you factor in all strengths and formulations, it goes up to about 3,000. So quite a few things going on here. Another way of looking at this is the cost per adjusted patient day. So in other words, how much do we spend on pharmacy per day? Look at the bottom numbers here. Again, following year over on a monthly basis, an amount. Typically, we're looking at about $300 to $350 per patient per day in the hospital. You see this little uptick here. Again, this is cost for pharmacy as well as overall supplies. That probably relates to the COVID pandemic where we had a reduced census, yet patients were still medically complicated. So this ratio actually went up a little bit. But this is yet another way to measure cost in terms of our pharmacy budget. It's convenient, it's just once a day, but it's basically about 14 times the cost of vancomycin. If you want to look over here, these are the top 10 medications used in the hospital in terms of IV medications and how much they cost. Surprisingly, I didn't realize this, but fentanyl is the most commonly used drug. 60,000 orders for it per year. Others that may not surprise you on Antithrombotic, which is Zofran, heparin, also pretty common. Dilaudid makes the list. Convenient, it's just once a day, but it's basically about 14 times the cost of vancomycin. Just bundled a lot with some of their enhanced recovery after anesthesia programs. That, along with vancomycin, make actually both of these lists. So in terms of usage, and also cost as well. So it kind of gives you an idea of how complex this is. So how do we balance all this out? This is a nice little cartoon here. And basically, I think it's important just to look at when a pharmacy is working on a formulary and developing it and maintaining it. Now you have to look at first of all, safety. What are the side effects of the medications? Is there misuse potential? What's the efficacy of the drugs? What's the quality of evidence? Do we have appropriate people looking at these things to determine the pros and cons of adding or subtracting a drug? And finally, and lastly, we look at cost, or reimbursement, which is a factor. And hopefully, if we do this right, we can get a balance between these factors and lead to a more rational and smarter prescribing pattern here. Now, I show that slide, and I want to give a follow-up slide here, and that's just criticisms of the formulary process. And I think we can all identify with this. I mean, it does in some ways limit healthcare provider autonomy, and I think that's understandable. Some centers, I think maybe 10% of academic centers have what's called an open formulary, as opposed to what we have here, which is called a closed formulary. Basically, they have situations, or their setup is where the docs can and healthcare providers can pretty much get whatever they want. And there's really no overriding pharmacy to kind of oversee this. Also, there's, we talk a lot about cost. Lots of, some people say it's needless hurdles and complexities. Another criticism would just be it's subjective and unsystematic, and that's something I hope I can dispel during this presentation. And some people feel like the P&T committee or Pharmacy, Nutrition, and Therapeutics committees are too empowered. Those are all valid criticisms of the system. They're valid here, and also they are valid for this presentation. I've talked a lot about money. I realize cost is a four-letter word to some and makes some people a little uncomfortable. I'm not going to say that cost is the most important issue, but it is an issue that we need to consider when we're talking about such large expenditures for our healthcare system. So traditionally, how is our pharmacy maintained? Well, this is a traditional setup up until 2018. And basically, we had these main subcommittees: formulary, which helped look at medications to add and subtract from the formulary; medication area, where we would look at any mistakes that took place, see if there was an opportunity for systematic improvement. We would look at antimicrobials, which is basically antibiotics and their usage; antithrombotics, looking at, again, self-explanatory, antithrombotic drugs, Coumadin, warfarin, the DOACs, all those types of things. The MUE stands for Med Use Evaluations. These are basically quality assurance projects that a lot of the pharmacy residents would do to make sure we were adhering to approved protocols for these medications, see if we could do better. And lastly, there's nutrition, which looked a lot at the TPN issues that our system encountered. These all filtered up to the P&T, or Pharmacy, Nutrition, and Therapeutics Committee, where decisions were made. And ultimately, after discussion, we made a decision, and then it was turned over to Med Exec for final approval. And that's the way it kind of worked. And it worked pretty well. But times have changed. It's not just WVU Hospital anymore. It's a whole healthcare system. There's at least 12 right now, and I think actually 13, and it seems to be growing almost on a monthly basis in terms of how many hospitals are involved. And again, it's not just us. It's all these other hospitals. And we're all working together. We all have the same electronic medical record, and it adds a layer of complexity to this. And that's what we want to kind of look into the nitty-gritty a little bit more in a minute. First off, though, I want to comment about Superman. I'm sorry, I've already talked about Superman. Let's talk about Batman and Robin. You may be saying, well, who are these guys here? This is Batman and Robin that I grew up with, played by Burt Ward and Adam West. And basically, you can look at these guys, their nose, their mouth, their eyes are all unprotected. So I would say they are not very COVID responsible superheroes at this point. Though Superman has gone more from a blue spandex to more of a black leather in terms of his wardrobe. He looks a little bit meaner and grumpier. The fallacies remain the same. They're still, all their facial orifices are exposed. And unless they can develop a COVID retardant bat spray, I'm still going to have to give them a thumbs down. So, getting now into a little bit of a deeper dive on what we're doing at WVU Medicine for our formulary, just want to start out with a couple of basically a definition. What is a formulary? What's the primary vehicle which medication availability, patient selection, use criteria, guidelines, restrictions, standards, non-formulary usage, clinical and economic outcomes, and all of other aspects of medication therapy regimens are managed. If you want to read more about this, you can refer to Appendix 1 and 1A. This thing is not a static, it's a flexible, it's a dynamic process. It's continually revised, okay? We maintain the formulary medication list. There's also opportunities for to get non-formulary medications. In other words, medicines that we don't stock in the pharmacy. There actually is a well-defined non-formulary mechanism by which we can get it. And also there's certain medications we call restricted medications. And these are basically restricted to specific indications, locations, and usages. One of the things we've tried to get away from recently is restricting these to specific provider services, because we find there's a lot of overlap between services and maybe wanting to use the same medication as their institution has continued to grow. So what we've kind of evolved into is what we call the Enterprise Pharmacy Therapeutics Committee. Again, this looks all across WVU Medicine. And I want to emphasize 2 points here. Number one, it's equitable representation of all WVUHS entities. In other words, all 12 or 13 hospitals all have a vote in this, okay? And the goal is to basically to standardize the policies and procedures so we're consistent across the organization. So what are the duties of the ePNT? Basically, in terms of formulary maintenance, we maintain the entire drug portfolio for the entire system. We need to do drug use evaluation. We're looking at drug usage and safety. And then finally, we also monitor the quality of the drug adherence, and potential outcomes regarding the use of the medications. So what's the present structure? This is a little different now, okay? It's similar to the previous traditional formulary or traditional P&T structure, but it's a little different now. So now we've got these committees. We've got the Antimicrobial Stewardship Committee, which basically, again, looks at the antibiotics, Antithrombotic, again, self-explanatory, looking at the, anticoagulants, reversibility, all those types of things. And then I'm going to go over hematology oncology, kind of maintains their own subcommittee because these medicines are such high cost, and you need to have experts looking at this to see if it's truly appropriate to add or not. A new perioperative subcommittee has been formed recently to look at perioperative medicine, appropriate use of medications, both pre and post surgeries. And now, the formulary kind of covered everything, but now the ambulatory world has expanded so much that really they need their own formulary as well. So that's also going to be a subcommittee. I mentioned these here: med safety management, nutrition, pain, radiocontrast agents, biosimilars, and radiopharmaceuticals. These are all things that are committees. They're in place, and they kind of answer right now sort of to the formulary committee where things are vetted, and then we make a recommendation. So basically all these committees meet both in local and an enterprise aspect of it, and then they make their recommendations to the enterprise P&T. So how is a drug approved, or how is a decision made? Basically, you have your subcommittees again, across the system. They make their recommendation to the ePNT committee. And again, this is a group that, as of right now, because of the pandemic, we have to meet kind of virtually. But again, it's every place gets one vote. It's kind of like a Senate more so than a House of Representatives, okay? So decisions are made there, it is approved, and then disseminated to our local P&T committees at all centers throughout the WVU medicine. And finally, if there's any controversies or any things that need to be acknowledged, the med exec committees will sign off on that. So how does the enterprise P&T differ from the local P&T? So basically, just to highlight a couple of differences in terms of formularies, enterprise handles the additions and deletions and standardization. The local P&T looks more at evaluation and implementation. In terms of med use, the enterprise looks at standardization of all order sets. They build them in Epic. And then the local P&Ts basically look at ways to restrict them. They can always add more restrictions if they so desire. In terms of medication safety, the enterprise develops a process and standardization for drug utilization and effectiveness, whereas the local P&Ts review the medication errors and safety at each of their centers and look for opportunities for improvement. And then finally, communication education. Again, the ePNT looks at a published formulary. And from a local standpoint, it's medication therapy management. We have a pharmacy newsletter. And I have several different ways of dissemination, which I will share with you in a few minutes. Okay, our next superhero is Captain America, or Cap, as some people call him. Again, this gentleman, again, one of my favorite superheroes. I like him a lot. He still struggles with the same problems that Batman and Robin kind of struggle with. All his face, nose, and eyes are all exposed. Thus, he would be at risk for transmitting COVID. However, I would say this is a sort of a military-oriented guy. He tends to follow orders quite well. And I think if we just explained to him the rationale behind using personal protective equipment, I think he would understand and fall into line with it very well. So even though I gave him a thumbs down for his outfit, I would give him a thumbs up in that I think he has potential to become very COVID responsible. Okay, so how just does a drug get added to the formulary? So basically, it starts out, you got to have a requester, which could be a doctor, a pharmacist, maybe a nurse. The drug is assigned to a pharmacy resident or staff, and they generate what's called a monograph. I'm going to show you an example of that in a little bit. Monograph is presented. at the Formulary Subcommittee, you may say the Formulary E Subcommittee. And questions that come up, and again, it relates to specifically, is patient care going to be improved with this drug? Is the drug safe? Is it an upgrade from what we already have? We look a little bit at the kinetics and dynamics of the drug. We would look at if we would have to restrict it or not to a certain area. Do we need to reach out to more persons with more expertise? Again, I've always encouraged our pharmacists, if there's a question about a GI drug, say rifaximin or something like that, we should reach out to the gastroenterologist. If it's a question about steroids and COPD, we should reach out to the pulmonologist. So try to bring in parties as they need be. Again, we've already mentioned this in terms of having hematology, oncology having their own committee. And then finally, and lastly, would be how would it be reimbursed? Again, I think it's what we try to do is look at it from a safety standpoint, then an efficacy standpoint, and then lastly, a cost standpoint. So the committee will actually vet this out, review the monograph, make adjustments in it, and ultimately a recommendation is brought up to the ePNT committee where it's discussed at a higher level. And again, if it's approved, it goes back to the local PNT committees for implementation and a formal EPIC build. If you want to look at an example of this, see Appendix 4. So I thought we might want to just take an example here. This is a drug called droperidol. This is one that came up fairly recently. This was reviewed in April. Okay, this is a drug that has kind of an interesting story. This drug was available back when I was a resident, and then it was taken off the market due to cardiac toxicity concerns. It's an antiemetic. Basically, it went off the market for a while, but then one company started to remake the drug, and then there was more literature review on this particularly in the area of emergency medicine, where they felt maybe we needed another look to see if it would actually add something to our formulary. So basically, here's the drug. We go through it, basically who requested, in this case it was emergency medicine, class of drug. We look at it, all the hospitals throughout the system, and what if there's who's using, who has it on formulary or not. We look at comparative drugs. We look at off-label indications, FDA-approved indications, all this stuff. It's pretty detailed. We look at efficacy, and in this particular case, we see it with studies looking at nausea, vomiting, headache, anxiety, all showing pretty good beneficial effects of droperidol on patients in the emergency medicine setting. But again, safety is paramount here. And then the American Academy of Emergency Medicine actually put out this positioning statement. And basically what had happened is, yes, this drug can cause a QT prolongation, but it's only at higher doses. When you use it like less than 2.5 milligrams, it's really considered quite safe. So actually we have data now showing efficacy and now its safety, okay? So continuing on with this, talk about box warnings, contraindications, warnings. We looked about adverse events, drug interactions, sound like drugs, monitoring requirements. All these things are vetted out. This is kind of like a pharmacopoeia. That's what the monograph kind of looks like. And lastly, we do look at cost. I just want to point this out. GPO tech is basically referring to inpatient cost, and 340B is outpatient cost. And these can vary depending on what the drug is. But again, it's not a particularly expensive drug. So anyway, this whole review process kind of, looked favorably upon this drug, okay? So basically, this was the final product from the Formulary Enterprise Formulary Subcommittee to the ePNT Committee. Basically, we would recommend, or was recommended, to add droperidol to the formulary across the system. We put in a kind of a position statement about safety. Even though the FDA recommends EKG monitoring, it's really only those situations where you're using doses higher than 2.5 milligrams. Also, because it is a single source provider, there will be times where there's probably some deficiency of the medication. So we just try to recommend good stewardship in using the drug maybe after 2 other drugs have failed. So that was the final recommendation to ePNT, and that was ultimately approved and was recirculated back to the local PNTs, and you'll be seeing this added to the formulary in the near future. So what are some other functions of the Formulary Subcommittee? Well, we removed drugs. I'm going to talk about Tygan in just a minute. Ranitidine was recently taken off the market. We developed med usage guidelines. If you're interested, again, I've got a lot of appendices at the end of this talk if you want to look for further reading if you're interested. Antiemetics. We talked a little bit earlier about albumin being a high-cost drug. We have usage usage guidelines in place for that. They do class reviews periodically, basically looking at drugs where there's lots of different drugs in a class. And, basically it's not so much a cost issue, it's just an issue of easier maintenance. We try to look at the drugs in terms of which ones has the best data, the best safety profile, that benefit the most patients. And we may limit it to 2 or 3 of the drugs in that particular class. And this is particularly important when there's an available therapeutic interchange where we can actually see a dose of their outpatient medicine and change it to an appropriate dose of their inpatient medicine. So you'll see some of these. One that was recently reviewed was SGLT2 inhibitors. Also, we have one in place for statins, PPIs. All these things are an ever-evolving process. I thought this was kind of an interesting story about Tygan. This is a drug that some of you guys may remember, trimethylbenzamide. I'll say up front, I was guilty on this. I kind of thought it was the drug we would use for an antiemetic for people that had prolonged QT intervals, anybody above maybe 450 or so. We would, a lot of times I would see the residents use this particular medication. I considered it was okay. But the reality is we actually did a little deeper dive on this because we do look at these things periodically to see, what drugs are we using and, rethink things, okay? And basically looking at studies, again, these were older studies from the 60s, and it really hasn't been anything more recent. They really showed no more benefit than just using placebo. So really this drug really did not work that well. Then we went back and looked at ordering physicians. We found it was like sort of a clustering of physicians that would order them. It was actually a limited number that sort of, probably that was just their practice habit and they ordered it. And again, I was, I certainly thought it was an appropriate drug to use. And so I prescribed a fair amount of it myself to hospitalized patients. And finally, we looked at it and we were actually spending about $100,000 per year on this particular drug that was really providing, we think, basically no benefit. At the same time, the reason we used Tygan a lot was we were afraid to use Zofran because we just thought that would prolong QTC intervals and increase our risk of torsades. People got scared of it. But actually, GlaxoSmithKline did a study, it was FDA mandated, where they looked at ondansetron and how much QTC prolongation actually occurs. They actually found it to be very minimal. If you gave 32 milligrams, which is a max dose per day, you prolonged it on average of about 20 milliseconds. If you gave just a single dose of like 8 milligrams, you only prolonged it by 6 milliseconds. So basically what we've had was a drug that had poor data in terms of efficacy, that was costly, and we could replace it with a better drug and a safer drug and wind up saving about $100,000 per year. So again, I thought this was kind of an interesting story. Again, it's a good thing. It's kind of like we are creatures of habit in that we do things and we kind of get in a habit of wanting a particular drug, but it's good to challenge these things every now and then because sometimes maybe the data is not that robust with them and maybe there's better opportunities or better medications out there. Okay, Iron Man, again, another superhero I like a lot. Industry experts really think Iron Man's really a very COVID responsive superhero. And I don't disagree a whole lot. I mean, he's very smart. He's got really some neat technology here. The only question I would have with him is I just wonder, like with these plates right here, if you watch the way they're put on, sometimes I wonder how well they seal up. They seem to be kind of slapped on rather quickly and haphazardly. So again, if you're looking at a COVID particle that's aerosolized, you're looking at about a micron in size. So I don't know if this could be compromised easily where there could be some COVID exchange going on. In general, I would say he's doing a pretty good job, but again, he's not like Captain America either. He's a little bit hard-headed and a little bit arrogant too. So again, for the most part, I think he's okay. All right. So some other things I want to these are just kind of examples of like some of the other committees. We talked about formulary, okay? That's sort of the main subcommittee we've talked a lot about. But now I want to talk a little bit about some of these other ones, just kind of briefly. First of all, it's the Antimicrobial Stewardship Committee. Lisa Keller heads this up. I just thought we'd talk about quinolones for a minute. They're very broad spectrum medications. They have a number of adverse side effects. And how have we responded to these particular medications? And I just thought I'd give you a kind of a timeline on this. Basically, in 2012, we started seeing more Pseudomonal resistance to the fluoroquinolones. In 2013, they were associated with C. diff infections. 2014, we put in more specific verbiage on restriction guidelines, basically for GI, GU, and as a second line for community-acquired pneumonia infections. Because of this, we actually were able to reduce the use of fluoroquinolones by 50%. So that was really good. Again, we looked at it from a national standpoint as well as a local standpoint, local audits, and communication with stakeholders, people that would use the drugs a lot, and really were quite successful with this. And things continue to evolve. In 2019, I think it was the AGA recommended that this was a very good drug to use for prophylaxis for SBP in high-risk patients with cirrhosis. And we actually did a med use evaluation on this drug, and we saw that we were really underutilizing, only using probably less than half the time where we actually putting people on suppressive antibiotics. So we actually expanded our restrictions at that point. And then in 2020, some new data came out about quinolones being a good option for step-down therapy in gram-negative bacteremias. So again, the restrictions were modified. So if you want to see the up-to-date restrictions for quinolones, look on Appendix 12. But I think it's just a good example of showing that this is, a drug with some side effects, but we're seeing expanded efficacy, and we're able to modify our restrictions to meet the new recommendations. Antithrombotic Subcommittee. This one, Lisa Markerman heads up. And I thought this was an interesting story here. We use 10A hit inhibitors a lot. And again, I encourage you to look at the website on this for physicians' reference tools. It's a very robust database for people, and it's all in-house data and very useful about their drugs, how to administer them, how to reverse them, all kinds of good topics. One of them is the 10A inhibitors. And again, they've become sort of mainstay for AFib and deep venous thrombosis. But one of the concerns when they first came out was, how do we reverse these things, okay? And over the years, rivaroxaban and apixaban, we basically, if somebody came in with a life-threatening bleed, we would give them Kcentra. But Andexxa was introduced a few years ago, and this was kind of an interesting story about, and how this, I just want to show you what degree of discussion that took place at the subcommittee level. But basically, the only data on this showed about a 90% reduction in anti-factor 10A activity, actually reduced the effectiveness of the rivaroxaban or apixaban. Didn't really correlate with homeostasis or improved clinical outcomes. It did have a higher rate of thrombosis. It was not compared head-to-head with Kcentra. When we actually went back and looked at Kcentra independently, we found that actually the studies show a reversal, the effects, basically the same percentage effect on 10A activity. So really, they do the same thing, and I'm not really sure if they actually gave better clinical outcomes. This was a single-site drug. There were only 30 initial sites. WVU Medicine was in a second tier. And then it became just a real big discussion of should we add this drug or not. The reality is this drug costs $25,000 per dose. Okay, so we really vetted this among the people that would use it, the trauma, the neurosurgeons, et cetera. Got a lot of different opinions, and ultimately it was decided, being a tertiary referral center that we are, we should probably have this drug. So ultimately, we did add this drug and basically with specific verbiage in terms of restricting it to life-threatening bleeding on patients. Pharmacy helps us to dose these things, and we also have a position statement. Basically, our thought is that either one of these drugs, Kcentra or Andexxa, are both good drugs in case of a life-threatening bleed and a person on a DOAC. But anyway, this required a lot of discussion. And again, it's a drug that probably has a benefit. It's a high-cost drug, but it is available to people that do need it. It's a very select population, but it is available. Okay, Ant-Man. Probably one of the lesser-known superheroes. I just put him in here simply because I just think he looks really cool. I like his mask. I think it covers everything up. It's kind of like Iron Man. And I would theorize that, once he shrinks, these seams probably shrink up quite a bit and probably even make him less likely to pass COVID along. So again, I think this guy looks cool and probably very COVID responsible as well. Okay, turning our attention to quality, okay. Dr. Learfall did a presentation, I think back in January, looking at all the measures that WVU Medicine is putting into place to improve safety and quality. And it's really important we do these, and they all look good and sound good, but do they make a difference? And we have to hold ourselves accountable in this regard. So basically, how has it improved? There's several different ways we look at this. First of all, we benchmark ourselves with other academic centers regarding certain drugs such as antibiotics. We look at medical errors. We look at trends, opportunities for improvement. We maintain dashboards with a specific taxonomy of errors, trying to find if there's any trends. We do periodic med use evaluations in drugs of interest. These are basically quality assurance projects, kind of similar to what some of our internal medicine residents do. I've included an example of one in Appendix 11. In terms of antimicrobials, we follow nosocomial infections, such as C. diff, MRSA, those types of things, to kind of follow along. These become or surrogate outcomes or surrogate indicators of increased resistance. We partner with other disciplines. I mean, I think the Medicine Quality Council here and the Pharmacy Nutrition Therapeutics Committee have started to work together on a lot of different things. There's a lot of overlap, and I think that only helps the situation. And then basically we've developed a variety of routes to disseminate things, such as emails. Obviously that's an old school way of doing it, but something, EduBlast, newsletters, all these types of things are available. And again, a big thumbs up to the pharmacy website under Physicians Reference Tools. Look at this, a lot of good information on this. We have the Medication Management Committee and Medication Safety Committee, and this, Dr. Maria Cumston heads this up. And again, this is where we look at all these, any errors that take place. We have what's called an event management system, which is formerly known as the PSNs, and these are just ways that we record errors that take place, and also adverse drug reactions. We look at all these types of things. Such an example recently was cefepime, where we knew nationally we started seeing data, but we also see in-house examples of cefepime, particularly in elderly folks with renal insufficiency, that they were seeing more neurotoxicity with these things, and it's led to some stewardship endeavors to try to improve its usage. We look at all harm events. See a lot of these related to insulin and heparin. We actually grade them in terms of severity, and you can see Appendix 13 to read more about that. We stay up to date with the different organizations, such as the Institute for Safe Medical Practices, or ISMMP. An example here of an intervention that was done is promethazine, which was used a lot. Obviously, it's Finnegan, right? We use a lot for nausea, vomiting, but IV or any type of injectable has been associated with limb loss because of its vesicant and can destroy vasculature. And even though we've used it in thousands and thousands of patients over the years, we've seen more and more of these events take place. And ultimately, the ISMP recommended to remove it, and that's what we did. So we don't have that IV anymore. Ironically, as we stated earlier, droperidol will be another IV anti-nausea medicine, which will hopefully somewhat replace that. We work a lot on policy development. One that's going on right now is missed delayed administration of medications. I've included that in as an appendix as well. Maintain a list of high alert medications. I'll talk about that. Sound alike, look alike drugs, and also maintain a safety newsletter. Lots of things going on. This is just an example of the dashboard, just kind of following along. We look at the number of medication-related safety events that occur on a monthly basis compared to last year. ADEs or ADRs, we can follow those. Sometimes we look at actually just surrogate outcomes. Again, looking at naloxone and flumazenil usage as a reflection of opioid and benzo overusage, and we can actually track those. Again, it's been fairly stable. We look at harm events. We look at various types of pharmacy errors in terms of a taxonomy here, and we keep track of all this stuff and looking for trends. Looking at it from a graphing standpoint, you can see right here, this is the pharmacy errors report. These are hospital errors. I'm just going to focus on the pharmacy errors for right now. But you can see over time from 2016 to 2020, kind of an uptick, and actually have come down a little bit here. So that's actually good, I think, and that we see less errors, but it can also reflect less reporting of errors. What might be a better way to look at is events reported by a pharmacy in terms of, catches before they reach the patient, events being identified, reaching the patient, but avoiding permanent harm. And then the one we don't want is events causing harm. And again, if you can kind of see this, you want this gray area to be as small as it possibly can be. Okay, so saying it another way, we want reporting of medications, recording of medication errors. We encourage that. We want our residents to submit these, anything that goes wrong. Everything's looked at from a system improvement process. What we want to try to minimize is these two things, the things that actually reach the patients, and particularly those that cause any harm. I just wanted to, just FYI, high alert medications. These are ones that I just want to say in general, not all, but in general, these require what we call an independent double check. In other words, before these medicines are administered, the nurses typically will do an independent double check to make sure it's the right drug, right patient, right dose, right route, all that type of stuff, and have to sign off on that. A lot of these recommend chemotherapy drugs, heparin drugs, insulin, all those things are important. Also just, again, sedatives and certain high concentrations of electrolytes such as potassium and sodium also required, are considered high alert, dual sign off. Just to pivot over to dissemination of information, I just want to make you aware of this. This is a new program called Lexicomp by Renee Sager. Give a tip of the hat to her in terms of developing this. This is really a new program acquired through Lexicomp. And basically what it does is Lexicomp is basically, you look that up, you see a drug, you see a pharmacopoeia, basically. It's kind of like a monograph we showed earlier. But this allows hospitals to put specific information related to that particular entity into the monograph. And it could be like if it's restricted, if it's considered a high alert medication, all kinds of information here that can go on. An example, just to show you, you can access formula links via the reference links or within the manage order link as well. So you have two ways you can access this particular thing. Just to give you an example, here, this is on Cipro. Basically, you have, if you pull this up, before you actually get to the formal monograph, which is sort of the national or just the universal data on ciprofloxacin, you'll see safety issues here. We'll see if it makes error look-alike, sound-alike list. It'll also look at the restrictions. And you can see these are different entities within WVU Healthcare. And the restrictions vary from institution to institution. As I said earlier, the ePNT makes the recommendation. The local PNTs can actually further impose restrictions if they see need be. I just want to show this. This is called the Pharmacy, Nutrition, and Therapeutics newsletter. I'm really kind of excited about this. Really lots of good information. It's published on a every other month basis, and this is a template by which we're formulating a new conference between pharmacy and internal medicine residents, and I think it's a good resource. We're looking at ways to make sure this is disseminated to actually a larger group of people, because I think it really helps nurses, pharmacists, docs, and nurses. So again, it's a really good endeavor. Again, Renee Sager heads that up. Okay. Spider-Man, personally my favorite superhero. He's very likable. I like him because he's humble. He comes from a humble upbringing, kind of the blue-collar superhero. I respect the fact he makes his own suits. And, I think he's doing an overall good job. My only question with Spider-Man is I don't know the density of the material by which he makes his suits. I imagine it's improved over the years. Keeping in mind an aerosolized COVID particle is about 1 micron in size. It just depends on how thick the mask actually is. But props to him for covering his eyes, nose, and mouth, though I may not want to have him running my COVID unit, so to speak, in the hospital. I would be happy to go out to dinner with him anytime. I think he's doing a really good job. So good job, Spider-Man. Briefly, and in the home stretch now, new challenges. I just want to share a couple things. These are things that PNT/formulary is looking at too. Number one, outpatient pharmacy versus inpatient pharmacy. They're both big entities now. The pricing is different on these drugs. GPO for inpatient, 340B for outpatient. So we've actually formulated a new subcommittee for outpatient pharmacy. Replacement factors, FFP, Kcentra, usually lives under the domain of pathology in the hematology lab, but there is so much overlap that, that's something that, has been in discussion about, should that be under the domain of pharmacy as well. Another thing that comes up periodically, and Dr. Sawari was commenting about this, is, we're a tertiary care medical center, and actually even the term quaternary comes into play here. We are, we should be practicing, cutting edge medicine, okay? And occasionally there's medications that maybe don't have the robust data behind them that maybe a doctor wants to use to gain some experience with them. And we need to have a consistent process by which a doc can obtain conditional use for defined outcomes. And again, it's one of those things that's kind of evolving, particularly with some of the drugs for sepsis, or should I say for shock, and then also for certain antimicrobials. And then I'm going to give a slide to each one of these two things here real quick, COVID and biosimilars. So COVID, what has pharmacy done for COVID? And I just thought I'd just, just kind of do this as did you know type slide here. Number one, we got more efficient in terms of how we do things, virtually, over the phone. We really were able to expedite a lot of processes. We learned a lot from a good standpoint in terms of COVID. Hydroxychloroquine was going faster than tickets to a Led Zeppelin reunion concert whenever some of the initial data came out that maybe not only treated COVID, but also prevented COVID. And there was a lot of buy-up, let's just say, of Plaquenil, and it depleted the resources. So this had to be restricted to either an FDA-indicated indication, such as like lupus, or approved by an infectious disease doctor. Another thing you may not have known is to reduce the amount of provider exposure to potential COVID patients. We restricted all MDIs to COVID patients. Okay, everybody else that was not a COVID patient basically got a nebulizer in terms of their beta agonists. And then we've continued to do that. So we've basically trying to conserve a resource. Also infusion times for certain antibiotics, not just the ones like Zosyn, but also vancomycin, they were increased so it would require less nursing exposure time to COVID patients. We helped maintain a COVID order set. Again, it's a multidisciplinary group. We recently removed hydroxychloroquine from the order set because it doesn't work. The convalescent plasma, again, that's a project going on by Dr. Peppers. Again, we've been involved with that under in quite a bit of detail. And then obviously remdesivir is the one getting the most attention. And again, this was a sort of an algorithmic approach. It was a statewide endeavor, again, multidisciplinary, and our pharmacy had a very active role in terms of developing the algorithm by which persons could attain this medication. Lastly, biosimilars. I hesitated to even put this in the talk, but I thought it was worthwhile, just so you know the term. Biosimilars are defined as biologic products that are highly similar to a reference product. They have no clinical difference, or I should say no clinical meaningful differences in safety, purity, or potency. Okay, they are considered therapeutically equivalent to the reference biologic product. In other words, we have every reason to think these are safe, identical monoclonal antibodies. You basically apply to monoclonal antibodies with autoimmune disorders, particularly seen a lot with, again, in the rheumatologic world, sometimes inflammatory bowel disease, and obviously in the hematology oncology realm. But again, they may not be compared head to head with the reference product. So we have to really look at these critically to make sure that they are safe to use, because for third-party payers will likely pick one of these and be agreeable to pay for it. And we want to make sure we can get the one where we can actually get reimbursed. Another thing is that it's a moving target. Sometimes 1 month an entity will pay for one of these medications, and then 6 months later it'll be a different one. So we basically have a dedicated committee looking at these right now. And again, you don't need to know a lot about them, but I just want you to know what the term biosimilars are. Okay, in conclusion, I just want you to understand formulary process, development, maintenance. It's really complex. It's detailed, it's dynamic, and it's robust. Many factors go into what goes on in a formulary, and I just want to say up front, and I think our pharmacists kind of have a united front on this. Safety is the #1 consideration, okay? It's looked at nationally as well as locally. Then efficacy is probably the second most important thing, making sure we have good evidence, quality of evidence, getting the right people involved to help make these decisions. And then reimbursement is, again, probably the last on that list, but it's still an issue that we need to look at. Pharmacy, the structure is designed to accommodate these ongoing needs, again, throughout our entire system. I want you to know that any of you guys out there, you can request that a drug be added to formulary. Look under pharmacy reference tools. There's a request form, and you can kind of see how the process is done. And again, hopefully now you know a little bit more about how the process plays out. Ways to keep up: there's the ePNT newsletter, there's EduBlast that we send out periodically, there's conferences. And finally, I just want to encourage the audience, there are ways to contribute. If you see something that you think could be done better, or an error that occurs, file a EMR on it, okay? get involved with the QA/QI projects. There's lots of committees that people consider. I consider these very high yield committees. You learn a lot, allows you to keep up to date, and you can make a valuable input into the overall healthcare at WVU. So just a couple quick other guys here, just in terms of COVID response. Darth Vader, honestly, he's an arch enemy, I guess you could say. He's not a superhero. He's made a lot of bad choices over time. But, in all honesty, though he may want to whack you with his lightsaber, he really is quite COVID responsible. He covers his eyes, his nose, his mouth, and is probably, more COVID responsive than any of the superheroes we've seen thus far. This is more of an anti-hero, simply known as Shocker. He's wearing a P100, which basically filters out 100% of particulate matter. I think it's 30 microns or so. No COVID's going to get through to him, and he's not going to give it to anybody else. So big shout out to Shocker. And then lastly, I just want to say, big shout out to all our frontline workers that deal with COVID patients. They are heroes, but I think we need to qualify this when we say there are superheroes, because in general, superheroes could do a better job. They need to do a better, they need to wear masks like the rest of us do. With that, I just want to thank some great people that have kind of helped me put this presentation together. I hope it was useful to you. There's lots of appendices where you'd like to read more. Feel free to do so, and I'd be happy to answer any questions. That concludes today's grand rounds. Thank you so much for your attention, and have a great weekend. Thank you very much.